On behalf of the American Heart Association, I would like to welcome you to today's webinar, Renal Disease in Patients with Heart Failure and Diabetes, Treatment Guidelines and Updates in Get With the Guidelines Heart Failure. My name is Renee Sednu, and I am a manager in Quality Outcomes Research and Analytics with the American Heart Association. To begin, I'd like to go over a few items so you know how to participate in today's event. If you would like a copy of today's presentation, you can download a PDF in the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please contact the GoToWebinar customer service team found in your confirmation and reminder email. At the conclusion of today's presentation, you will receive a link to access today's recording, as well as an invitation to complete our feedback survey. We welcome you to submit text questions for our presenter at any time in the questions pane of the control panel. We will collect your responses and address them during the Q&A session at the end of today's presentation. It is my pleasure to now introduce our speakers for today. Dr. Robert Eckel is a distinguished alumnus of the University of Cincinnati College of Medicine, professor of medicine with appointments in the Division of Endocrinology, Metabolism and Diabetes, and Division of Cardiology, and former endowed chair in atherosclerosis at the University of Colorado School of Medicine Medical Campus. He was also a member of the Scientific Advisory Council of the National Institute of Diabetes, Digestive and Kidney Diseases at the National Institutes of Health. In addition, he served as president of the North American Association for the Study of Obesity and president of the American Heart Association. Welcome, Dr. Eckel.
Good, thank you very much, Renee. It's good to have everyone with us here this morning on this webinar. This is an incredibly important and evolving topic that really is an outcome in part of the No Diabetes by Heart program, which is a joint venture between the AHA and the ADA. I've already been announced, so we don't need to belabor information on this slide. And my disclosures really relate to activities that are mostly in biotech firms that ultimately don't have products on the market. Novo Nordisk is the only one that does, and I can assure you that advisory board role that I play with them has nothing to do with the content directly that I'm going to be presenting today. We're talking about here updated guidelines that relate to chronic renal disease and heart failure in patients with type 2 diabetes. Now, No Diabetes by Heart was an initiative put forth to ultimately accomplish the goal of reducing cardiovascular disease deaths, heart attacks, congestive heart failure and strokes, and people living with type 2 diabetes. This has been jointly sponsored by a number of different pharmaceutical companies, including Boehringer Ingelheim, Lilly, and Novo Nordisk as founding sponsors, and Sanofi, AstraZeneca, and Bayer as national sponsors. Ultimately, this now has extended from heart disease and diabetes to renal disease too, and heart failure, which really are incredibly important outcomes of patients living with type 2 diabetes at risk for these outcomes to follow. So ultimately, the No Diabetes by Heart program, I thought we'd start here just briefly to identify the various pillars of activity that are part of No Diabetes by Heart. The first is in consumer activation, which is increasing the awareness and understanding of the connection between type 2 diabetes and cardiovascular disease. These are broad strokes reaching out to a wide variety of both the population and healthcare professionals. There's the patient resources and support pillar, which is a comprehensive portfolio of patient education, resources, and self-management tools. It's really incredibly important to get our patients involved in their own evaluation and care going forward. The third is the professional resources and education pillar, and that's to improve healthcare provider adherence to diabetes standards of care for management of cardiovascular disease and related risk factors in patients with type 2 diabetes. And the final is on quality and systems improvement. Here's a big tent, ultimately, to be part of this program. That's to implement programs and activities to help healthcare systems apply and practice the most up-to-date evidence-based treatment guidelines for primary and secondary prevention of cardiovascular disease and stroke events in patients living with type 2 diabetes. So let's look at some data here. There's more than 30 million Americans that live with type 2 diabetes. In fact, I think most of these are type 2. 90 to 95% of those with diabetes are living with type 2. And I might say, kind of in a tangent kind of manner, that ultimately there are patients with type 1 diabetes who share many of these same risk factors. And these patients are living quite longer these days, but the intent of No Diabetes by Heart clearly is directed to the large majority of people living with diabetes. Cardiovascular disease, as most of us know, is the leading cause of death for people who live with type 2 diabetes. And people with type 2 diabetes are now 2 times more likely to develop and die from cardiovascular disease, such as heart attacks, heart failure, and strokes than people who do not have diabetes. And for adults above the age of 60, having type 2 diabetes and cardiovascular disease shortens life expectancy by an average of 12 years. That's an incredible impact, being at age 60 and having your life be shortened by over a decade because of the coexistence of type 2 diabetes, cardiovascular disease risk, and related outcomes. Now, in 2015, I shared part of a multi-authored publication by the American Heart Association and the American Diabetes Association called the Update on Prevention of Cardiovascular Disease in Adults with Type 2 Diabetes in light of recent evidence. And I must say in parenthesis that the light of recent evidence has changed substantially since 2015. And we're looking at a whole platform and ultimately via going forward that modifies how we approach patients with diabetes. Now, this slide is currently the approach utilized by the ADA and also shared by No Diabetes by Heart that looks at the beginning of decision cycle for patient-centered glycemic management in those living with type 2 diabetes. First is to assess the key patient characteristics. The second is to consider specific factors that impact our choice of therapy. The third is shared decision-making to create a management plan. Isn't that true of all healthcare these days? The fourth is agreeing on this management plan going forward. The next is implement the managed plan to make sure that patients understand what we're doing and why we're doing it. The next is ongoing monitoring and support, including emotional well-being and the other items shared here under this set of bullet points to follow. And finally, review and agreeing on the management plan that really relates, I think, in monitoring going forward in terms of the success of all the steps that preceded the management plan that's put forth. Ultimately, the goals of this care is to prevent complications from diabetes and optimize the quality of life going forward. Now, first, assessing the key patient characteristics. We're not going to review all these in detail, but just to list these because they're so critically important. Current lifestyle is so critically important. In terms of nutrition, it's not only the quantity of the diet, meaning how many calories they're eating to induce weight reduction, but also the quality of the diet. This is incredibly important for people living with diabetes. The assessment and management of comorbidities, excuse me, including atherosclerotic cardiovascular disease, chronic kidney disease, both of which relate to heart failure to follow. Clinical characteristics that affect the management plan, including the age of the patient, the A1C, and weight. This is called the individualization of goal-setting behavior that we carry out routinely in patients with type 2 diabetes. Issues that are patient-centric includes motivation and diabetes distress or depression that enter into the decision-making process. And finally, importantly, and increasingly importantly, are cultural and socioeconomic issues that relate to the management plan and its success. Now, complicated slide, I'm going to try to summarize this very quickly by going from left to right at the top. Indicators of high-risk atherosclerotic cardiovascular disease in terms of a risk for an event or people with established cardiovascular disease, we're looking at a choice of agents going beyond lifestyle that relate to mostly the SGLT2 inhibitors or the GLP-1 receptor agonists. If the A1C is above an individualized target and we want to proceed, ultimately we're thinking about issues that need to avoid hypoglycemia, and those are drug choices as shown here, the DPP-4 inhibitors, the GLP-1 receptor agonists, the SGLT2 inhibitors, and the thiazolidinediones. Those that need to minimize weight gain or promote weight loss, we're looking here at the GLP-1 receptor agonists and the SGLT2s, and those that relate to out-of-pocket cost, and those basically are the sulfonylureas and the TZDs to a large extent. Now, back up here, the issue is to whether metformin should be present initiating therapy in patients who have had a recent event, who have been diagnosed with type 2 diabetes, remains debated in terms of the view of the American Diabetes Association and that of the European Association for the Study of Diabetes and the European Society for Cardiology. Anyway, the metformin issue is not something to get bogged down on. Most of our patients are on metformin already, and the choice of a GLP-1 receptor agonist or an SGLT2 inhibitor should relate to the clinical trial data that we now have available. Now, Target Type 2 Diabetes is a program to spotlight on how type 2 diabetes relates to cardiovascular disease and joins up with Get With the guidelines that the AHA has been part of now for nearly a decade. Now, ultimately, the goal of this program to target type 2 diabetes is ultimately to address healthcare professionals and the ability to manage patients with type 2 diabetes, both out of the hospital and once hospitalized with a cardiac-related condition, or even perhaps beyond that, that relate to the prevention of a cardiovascular disease event to follow. Ultimately, this has a series of activities, including acknowledgement of the guidelines that currently exist, ultimately resources that one can link onto to provide information to affect the healthcare professionals' assessment and care of patients, a series like this one of podcasts and webinars that ultimately can be accessed readily at the AHA website or the NoDiabetesByHeart.org website, and quality improvement, learning about ultimately how to improve the quality of care going forward with Give Your Type 2 a Take 2 approach to the public in general, learning to live with type 2 diabetes and putting you at a lesser risk for heart disease and stroke going forward. Now let's look at simply some examples, a series of webinars and podcasts that are currently available, and I presume this one's going to be added to this list. Some sample resources in terms of No Diabetes by Heart Pocket Guide, shared decision-making guides, clinical case review options, a series of slide decks. Boy, these are incredibly valuable, and I've had the privilege of sharing in some of these. And then for patient resources, a series of programs our patients can ultimately link to and be further informed. And some of these programs are in Spanish too, and this is important because we have a large percentage, significant minority of our populations at high risk with type 2 diabetes who in fact are not English speaking. So this is kind of the example of the sample resources that you can access readily and apply to your assessment and care of patients with type 2 diabetes. Now, the program's entitled Diabetes and Chronic Kidney Disease and its relationship to congestive heart failure. Let's proceed systematically going forward. Here's an overview of causes of chronic kidney disease. Now, I'm going to be an internist here first and not a nephrologist, and you could be a pediatrician or a family practitioner. These are the kinds of things to think of in patients who in fact have chronic kidney disease. Diabetes, a leading cause of progressive renal dysfunction. Hypertension, often present in patients with type 2 diabetes, links to that relationship between diabetes and chronic kidney disease. However, hypertension in the absence of diabetes can also be a cause of chronic kidney disease. All forms of glomerulonephritis, often presenting with hematuria and proteinuria, but always not both. This is another cause that needs to be assessed when we evaluate patients with chronic kidney disease. Systemic vasculitis, ultimately polycystic kidney disease, and drugs that impair renal function. I may not have covered everything here, but I suspect that's 95% of the causes we know about and assess clinically for patients with chronic kidney disease. I thought I'd present a case that's fairly typical of the type of patient we're thinking about here today. This is, going forward, this is an individual who has a high school graduation weight of ultimately 162 pounds and a BMI of 23.2. So this 47-year-old guy weighed actually 162 at high school graduation. I like the high school graduation weight because a lot of people think back as to what their weight was at the time they graduated from high school. Ultimately, then he was active during college, but then took a sedentary job and began eating excessively, less active at times, and gained around 40 pounds over 15 years. Type 2 diabetes was diagnosed at age 42 when his weight was 232, a BMI then of 33.3 kilograms per meter squared. Subsequently, he developed left arm pain while bowling 2 years ago, and he had a PCI with a drug-eluting stent that was placed. He's been hypertensive since college, but untreated until his PCI. Multiple self-prescribed lifestyle attempts of weight loss have failed, and he's not sought additional help to get him to lose weight. His family history is positive for type 2 diabetes, but only late onset atherosclerotic cardiovascular disease. And over the past 2 to 3 weeks, he's noted some dyspnea while walking his dog. Lots of issues here in this 47-year-old guy, too young to have all these issues to deal with clinically. Now, he works a sedentary job as a computer analyst. He has no tobacco history. He drinks 3 beers on weekends. His diet admits to 2 servings of fruits and vegetables a day and 1 serving of whole grains daily, very poor and complex carbohydrate. Fish once a week. He doesn't read food labels, and he watches his carbohydrate intake, but not his sodium intake. Now, by the way, these are important lifestyle-related questions we should all be asking in our practices. His exercise is limited to dog walking around 15 minutes twice a day. His current medications are lisinopril 40 milligrams a day, aspirin 81 milligrams daily, atorvastatin 40, metformin 1700 in the morning and 850 in the evening, and he's on sitagliptin as his other glucose monitoring therapeutic, 100 milligrams a day. Physical exam 225, BMI 32.3, waist circumference 44. In general, when BMIs are above 30, you don't have to worry so much about waist circumference, particularly in men. That's where it is. Pulse was 86, blood pressure 148 over 68. And by the way, just about his blood pressure, he has systolic hypertension, but look at the pulse pressure, the difference between his systolic pressure and his diastolic pressure. By the way, probably more than systolic hypertension, the pulse pressure is probably one of the greatest predictors of bad outcomes to follow. His extremity fat is reduced. His legs and arms are fairly thin, but there's no buffalo hump or striae. So now as an endocrinologist, this patient probably doesn't need a workup for Cushing's syndrome or Cushing's disease, but that's something you should keep on the back burner. He has trace peripheral edema, and his monofilament and deep tendon reflexes are normal, so no apparent neuropathy by a crude examination. Here is labs, his A1C 7.4%, his total's 174, triglycerides are above normal 220, HDL's low at 38. His LDL cholesterol 89, it's under 100, but this man now has atherosclerotic cardiovascular disease. You could argue that it would be under 70 ideally, and maybe even under 55. Liver transaminases, both a bit elevated, not terribly high, but suggest maybe the presence of non-alcoholic fatty liver disease. Urinary microalbumin to creatinine, somewhat elevated at 360 milligrams per gram, and his estimated glomerular filtration rate is reduced at 43 milliliters per minute. So that's the case, has common kind of comorbidities related to type 2 diabetes, including renal disease, cardiovascular disease, and potentially now a risk for heart failure. So let's look at diabetes, heart health, and kidneys, a triangle of risk. Approximately 1/3 of people with diabetes develop chronic kidney disease. In my experience, I would say it's 2/3, but nevertheless, it's 1/3 based on population data. Diabetes can damage the blood vessels in your kidney, which can eventually lead to chronic kidney disease. That's a fairly simplistic statement. That's something that we're all pretty aware of. And high blood pressure, as we mentioned earlier, can certainly worsen kidney damage and contribute to diabetes-related renal disease and ultimately heart attack and stroke to follow. Now, if we look at the natural history of type 2 diabetes and kidney disease, here's the diagnosis of type 2 diabetes, and we're looking at cardiovascular disease death, which is a fairly hard outcome related to the onset of diabetes. Now, I'm going to make a point here, and that many people with impaired fasting glucose or impaired glucose tolerance, who we call pre-diabetic, ultimately also have a risk for cardiovascular disease-related outcomes. Now, death is the outcome we want to prevent. And here are the issues that will lead up to that. Functional changes in the tissues, such as those that relate to the development of chronic kidney disease. Structural changes follow, but rising blood pressure and hypertension precede this in most patients who develop chronic kidney disease. Microalbuminuria is not kidney disease. It's a leaky basement membrane that may predict the progression to macroalbuminuria to the right. But microalbuminuria can be transient and reversible. It's not kidney disease. It's simply a basement membrane where if you looked at the escape of proteins from the vasculature, you can find albumin leakage into the lower extremities. So this is the same kind of thing we're talking about with microalbuminuria. But once macroalbuminuria develops, and ultimately kidney disease progresses that relate more specifically now to diabetes and hypertension, we see ultimately a rising serum creatinine and finally end-stage renal disease that must be managed by hemodialysis or renal transplantation. Now, the thing about kidney disease and diabetes that link up so importantly to heart disease is not only atherosclerotic cardiovascular disease, which we know clearly is a consequence of both diabetes and chronic kidney disease. We're linking this whole issue with the development of heart failure. Ultimately, type 2 can lead directly to heart failure. Heart failure can worsen glycemic control. Type 2 diabetes, as we've already covered, can lead to chronic kidney disease. Ultimately, chronic kidney disease can lead to heart failure, and vice versa. Once heart failure develops, particularly with reduced ejection fractions, kidney disease can worsen. That's a whole management of fluid and electrolyte balance. But then as we think of electrolytes, sodium retention occurs with kidney disease, and sodium retention can lead to heart failure, and heart failure through mechanisms relate to renin, aldosterone, and angiotensin can lead to more sodium retention and perhaps even more kidney disease to follow. So this is a vicious cycle in terms of the relationship of diabetes to kidney disease to sodium retention and heart failure as the ultimate outcome of this relationship. Now, ultimately, diabetes care annually in the issue of January comes up with what they call the standards of medical care in diabetes. We reviewed those therapeutic guidelines related to medications already, but ultimately the guidelines have now been updated for 2021 and include renal disease and heart failure. And I should point out, under the leadership of Will Cephalou when he was our Chief Science and Medical Officer, and I co-served with Will as President-elect, and this recent year, Bob Gabay has been added as our Chief Science and Medical Officer. These standards of medical care have been updated when significant clinical trial data have been made available sufficient to modify the guidelines. So we don't have to wait for a whole year for the January issue to come out to be updated on important recent clinical trials that impact our assessment and care of patients who live with type 2 and, by the way, type 1 and rarer forms of diabetes to follow. So these are abridged standards that are available for primary care physicians and make things a little simpler than having to read hundreds of pages of recommendations to follow that are part of the standards of medical care in diabetes. Now, of importance, in terms of the topic before us today, in October, a joint venture was put forth, again, between the ADA and the AHA on the cardiorenal protection with the newer anti-diabetic agents in patients with diabetes and chronic kidney disease. This is mostly a statement from the ADA, but certainly is underwritten by this No Diabetes by Heart program, which has been shared by the two professional organizations. Let's look at these updated guidelines that relate, I should call them recommendations, but they're guidelines. I think we could argue a little bit about how guidelines do differ a little bit with recommendations, but both are evidence-based. I think guidelines are a little bit more stringent in terms of the criteria that are utilized, but don't get hung up on this relatively unimportant difference. So as we look at the scientific basis for new measures and get with the guidelines on heart failure, these are now guidelines. This is get with the guidelines, not in fact the standards of medical care, but they overlap very much with the updated standards of care that the ADA puts out annually. Let's look at the SGLT2 inhibitors for type 2 diabetes and chronic kidney disease. The percentage of heart failure patients with type 2 diabetes and chronic kidney disease who are prescribed SGLT2 inhibitors at discharge, this is an important update to get with the guidelines. Another thing is the use of ACE inhibitors and angiotensin receptor blockers, or ARNIs, for the treatment of albuminuria. And this is related to the percent of heart failure patients with diabetes who have albuminuria who are prescribed an ACE inhibitor or an angiotensin receptor blocker or an ARNI at the time of discharge. And I think this whole field has even been evolving since the information was provided for the update of the medical standards of care, but I think have been updated here in terms of get with the guidelines. So let's look at the standards of medical care published in the ADA Diabetes Care Journal for 2021. And this is the use of SGLT2 inhibitors for type 2 diabetes and chronic kidney disease. Guideline 11.3, and by the way, the medical standards of care have, I think, 21 or 22 different sets of guidelines that relate to various aspects of diabetes. I may not have that number accurately remembered, but there are a series of steps. So the set of guidelines under section 11 are those that I'm relating to here. In section 11.3a, for patients with type 2 diabetes and diabetic kidney disease, consider the use of an SGLT2 inhibitor in patients with an estimated GFR greater than or equal to 30 mils per minute, and that's expressed per meter squared, and the urinary albumin excretion, or in other words, macroalbuminuria above 300 milligrams per gram of creatinine a day. And that's a level A evidence now from the clinical trial data that has been accrued using a series of different SGLT2 inhibitors. And in terms of 11.3, this states, in patients, this is B, in patients with type 2 diabetes and diabetic kidney disease, consider use of a sodium glucose transport inhibitor, an SGLT2 inhibitor, additionally for cardiovascular disease risk reduction when the eGFR and urinary albumin creatinine ratio are greater than 30 or greater than 300 milligrams per gram, respectively. So here, either one of these can relate to the use of an SGLT2 inhibitor to modify the natural history of chronic kidney disease and cardiovascular disease risk. And finally, under option C, is in patients with chronic kidney disease who are at increased risk for cardiovascular disease events. The use of a glucagon-like peptide receptor 1 agonist reduces renal endpoints, primarily albuminuria and progression of albuminuria and cardiovascular disease events to follow. Again, level A evidence, that means you should do it. The idea here is, which one do you choose? Do you choose a GLP-1 receptor agonist or an SGLT2 inhibitor? I would think it would relate mostly to the patient who's more at risk for heart failure, or ultimately the one that relates mostly to the modification of atherosclerotic cardiovascular disease risk. And that's reviewed in the treatment algorithm that the ADA puts forth each year, or updated when needed, in terms of the standards of medical care related to pharmaceutical choices for treatment of patients with type 2 diabetes. Now, the FLOW trial, which is also using semaglutide now, may in fact be additional validation of the use of a GLP-1 receptor agonist. We'll just have to be patient for relating to how that influences the outcome, specifically that relates to cardiovascular disease events in progression of renal disease to follow. Now, in terms of the ACE-ARB issue, or the use of ARNIs for albuminuria, in terms of the management of kidney disease more specifically, here's stated in 11.7, in non-pregnant patients with diabetes and hypertension, and I presume we're talking there about type 2 diabetes for the most part, but type 1 could relate to, but the trial data are probably greater for type 2 for sure. And by the way, randomized controlled trials in type 1 really are not existent. We really can't turn to the kind of randomized controlled trial data in type 1 we can in type 2. Either an ACE inhibitor or an angiotensin receptor blocker is recommended for those with modestly elevated urinary albumin to creatinine ratio. That's 30 to 299, so-called microalbuminuria. That's level evidence B, and is strongly recommended for those with urinary albumin to creatinine ratios in the macroalbuminuric range, and or an eGFR less than 60. So we're really starting to talk about really early stage 3 chronic kidney disease. So ultimately now we have a modified guideline or recommendation going forward that relates to ARBs and ACEs in terms of the management of these patients. An ACE inhibitor, this is 11.9, or an angiotensin receptor blocker is not recommended for the primary prevention of chronic kidney disease in patients with diabetes who have a normal blood pressure, a normal urinary albumin to creatinine ratio under 30, and a normal eGFR. This, in fact, is strongly evidence-based. So we don't need to use these in terms of a preventive strategy for modifying the natural history of chronic kidney disease in those with type 2 diabetes who do not have kidney disease, as manifested by any of these criteria in 11.9. Then I should turn basically to a set of guidelines that includes about every organization we can even list here, that was published in 2017. And this was for the prevention, detection, evaluation, and management of high blood pressure in adults. This is a class 2B recommendation. And ultimately, in adults with diabetes and hypertension, ACE inhibitors and ARBs may be considered in the presence of albuminuria. The level of evidence is B. And NR, I think, stands for not recommended. But nevertheless, this clearly relates to the updated nature of the Get With the Guidelines program that has modified this based on substantial data to support this modification going forward. So I'm going to now turn to Christina to further the conversation about updates to Get With the Guidelines, specifically those that relate to heart failure. Christina, thanks for being on board with us.
Thank you, Dr. Eckel.
Thank you, Dr. Eckel and Christina. Thank you for joining us. As a reminder, we welcome you to submit text questions in the questions pane of the control panel for the Q&A session at the end of today's webinar. And it's now my pleasure, as Dr. Eckel mentioned, to introduce Christina Sterzing to the presentation. Christina Sterzing is the Healthcare Data Manager in Quality and Health IT at the American Heart Association. Christina, the floor is yours.
Thank you, Renee. And again, thank you, Dr. Eckel. That was a great presentation about how patients with heart failure and diabetes can be impacted and how to work with those with renal disease. So what I'm going to cover today are some of the updates that took place in December of 2020 that we incorporated into our Get With the Guidelines heart failure InfoSario registry platform tool for those of you who use the full form. Now, next slide, please, Renee. Thank you. For those of you who are using the limited form, which is just a slightly shorter form, you did not receive these updates because these were in place for the full form users, as there are not recognition programs tied to this at this time. Next slide. Back in December, we did send out an email and provided information to our users about the updates. And so I just wanted to reiterate kind of the summary of these updates on this slide. So there were a handful of data collection changes which are reflected in 3 measures that we will review today. So on the admission tab, there is a new medical history option to indicate whether the patient has had a kidney transplant. Then on the discharge tab, we added in urinary creatinine, urinary albumin, eGFR, UACR. Each of those lab values or calculations support the measures that we will review here, the SGLT2 inhibitor for type 2 diabetes and CKD, and the ACE-ARB-ARNI for albuminuria, and then the defect-free renal protective medication composite, which is a composite of the 2 aforementioned measures. Next slide, please. So now we'll take a look at, just very straightforward look at what those changes look like in the tool. So again, on the admission tab under medical history, which is, you're all familiar with the medical history section, we've added a kidney transplant option. So the kidney transplant may exclude some patients from the measures that we added. So you will now be able to indicate that on the form. Next slide. Then on the discharge tab, one of the 2 different screenshots here show the different labs that we have added to the tool. So EEGFR, that calculation can be either captured in the medical record and manually inputted into the form, or there's a variety of calculating tools that you could use to input that into the form. And you will also have an opportunity to enter in the urinary albumin values at discharge, the urinary creatinine at discharge, and then the urinary albumin to creatinine ratio calculation as well. And those are found under the lab section on the discharge tab. Next slide, please. So each of these are required labs as indicated by the errors under the My Task section now in the form. So if you are leaving those fields blank, you will get an error, which means that you won't be able to save the form as complete. However, you will be able to save the form and exit. You will just have those open errors reminding you that we are collecting and requiring these fields going forward. Next slide, please. So a couple of things to note for these discharge lab values. The EGFR, we recommend that you use a validated formula such as the chronic kidney disease epidemiology collaboration equation. So make sure that as you are collecting that, and if it's a calculation that's in your medical record, make sure that it probably is a validated formula, but just double check that before entering that manually into the tool. The UACR, or urinary albumin creatinine ratio, just take note that if you don't have a inpatient or admission record of the urinary albumin or urinary creatinine, you may go to prior lab results if they're available in the medical record. You may not find that there, but if that's something that was not performed during that patient's admission, you may go back to prior lab results. And also one note, and this has come up a couple times from users that I wanted to address. So urinary creatinine and serum creatinine are two different lab values. So you would just want to make sure that you're capturing, capturing the urinary creatinine in that section. We also collect serum creatinine levels, but they are two different labs. And under the additional medical exclusions for some of the medications, while they're not on the form, in the coding instructions, you'll note that pregnancy and acute kidney injury are acceptable reasons for not prescribing an ACE or ARB at discharge. So when you're, if a patient falls into either of those categories, you're still able to select none contraindicated or NC on the form. In patients with acute kidney injury or those who are undernourished, if that applies to a patient, that is an acceptable reason for not prescribing SGLT2 inhibitors at discharge. Next slide, please. All right, now let's talk about the new measures that were added to so you can track your patients with those who were prescribed an ACE, ARB, or ARNI at discharge, and those who were prescribed SGLT2 inhibitors at discharge. So on the operational report screen, you'll see a new section that's a new bundle that's titled No Diabetes by Heart CKD, and the two measures can be selected at the same time or individually to run and view your case lists and perform other analyses on those records. Next slide, please. And then finally, we do have the defect-free composite measure, which is listed here under the defect-free measure bundle entitled Defect-Free Renal Protective Medication Composite. So you will be able to run that, and that looks at the composite of the two measures we've talked about already, SGLT2 inhibitor and the ACE-ARB-ARNI measure. So it will look for patients who had what we're calling defect-free care, meaning they were prescribed or excluded for both of those measures. Next slide, please. So a couple things to make it a little bit easier to understand which patients are included or excluded for the measures that we added here. This is the SGLT2 inhibitor. So what we're looking at here is the percentage of the heart failure patients that have type 2 diabetes and chronic kidney disease, and if they were prescribed SGLT2 inhibitor. So of course, we'll look at the patients with heart failure, either a primary diagnosis with CAD or without CAD, patients with a history or a new diagnosis of type 2 diabetes, eGFR levels of 30 to 60 milliliters per minute, or eGFR of greater than 60 milliliters per minute, and a UACR value of greater than 300. But we are also excluding patients that have contraindications or medical reasons for not prescribing SGLT2 inhibitors, so that would be captured under anti-hyperglycemic medications currently. So it would exclude any of those patients with those contraindications or medical reasons. It will also exclude patients with a GLP-1 receptor agonist, those patients on dialysis, those with the history of kidney transplant, patients on comfort measures only, and then those patients who were discharged to hospice, left against medical advice, or were discharged to another healthcare facility. Acute care facility, sorry. And now let's look at the ACE, ARB, or ARNI inclusion and exclusion criteria. If you could go to the next slide, please. Let's see, I think you need to go back actually one. There you go. Thanks. So this one, we are looking at patients with heart failure and diabetes who have albuminuria, who were prescribed on ACE, ARBs, or ARNIs at discharge. So again, we're looking at the inclusion criteria for patients with heart failure with or without CAD, and those who have a history or new diagnosis of type 2 diabetes, and a UACR value of greater than 300, and then excluding any patients with contraindications for not prescribing ACE, ARBs, or ARNI, patients on dialysis, patients with comfort measures only, and patients that were discharged to hospice, left against medical advice, or another acute care facility. Next slide is looking at the defect-free renal protective medication composite. So percentage of patients who received either or both, patients who received both renal protective medications, SGLT2 inhibitor, and ACE or ARB or ARNI. And it includes patients who met criteria for both measures, but excludes patients who were excluded from both measures. So that's a good composite measure to run if you would like to see that defect-free care for your patient population. Next slide, please. And we've come to an end discussing the updates that took place in December, but I wanted to give a really brief update on some exciting changes that are coming later this year. And one of them is introducing SGLT2 inhibitor as a standalone medication class. So this goes back to some of what Dr. Eckel presented with the importance of SGLT2 inhibitors as not just a diabetic or anti-hyperglycemic medication, but also as an important heart failure medication for patients with or without diabetes. So as that became FDA approved last year, we are introducing SGLT2 inhibitor as a standalone medication class. It will be, it's currently under anti-hyperglycemic medication, so we're just kind of taking it out of that, that class and making it its own. We already collect SGLT2 inhibitors, so really the change is just that we are making it its own class, so it will be located in a different section or a different placement on the form, and has its own list of contraindications, and you know, to reemphasize the importance of this new medication. We'll also be introducing a composite measure later this year that shows the 4 medications that provide optimal care for heart failure patients, SGLT2 inhibitor being one of them, aldosterone antagonists, evidence-based beta blockers, and ACE/ARB or ARNIs will be part of that composite measure. We are also asking users to begin entering their medications at admission as if it's a required field. These have been on the form since probably heart failure, Give the Guidelines heart failure was created, but it's always been an optional field for full form users. We are going to make this a required field soon, so you might want to start making sure you're entering that now. Once we require that on the form, there will be errors triggered whenever that those fields are skipped. So keep an eye out for information about that. We also will be updating the tool for the Task Force for Performance Measure updates that came out in November, I believe. So there were some additional labs and other criteria that were recommended in the Task Force for Performance Measures updates, and we will be reflecting that in the probably early summer this year, so keep an eye out for that. And also this list here was just a brief overview of some of the updates, but it's not all inclusive. We have more things coming to make the tool even easier to use, and with new dashboard highlights and other exciting changes. So stay tuned for communications about all of those update details. And I believe that was the last slide, so we're probably, yes. Thank you. I'll hand it back to Renee. Thanks, everyone.
Thank you, Christina, and thank you, Dr. Eckel. At this time, we will now move into the Q&A session. As a reminder, you can still submit questions for our presenters through the questions pane in the attendee control panel. And I also wanted to let everyone know that you are able to download a PDF of today's presentation in the handout section of your control panel. If you're having any trouble downloading that presentation, we will be sending a follow-up email to all registrants with both the recording and the presentation. So you will see that coming to your inbox in about an hour or so after the event. So we have several questions that have come through, and I'm just going to go ahead and read the first one here. Dr. Eckel, I think this one would be for you. So the question is, of course, we are addressing heart failure and diabetes, and with these two diseases, these two diseases come with renal problems. I think we should include endocrinologists and nephrologists on our discussions. So, Dr. Eckel, I know that's more of a comment, but do you have anything to add to that statement? And Dr. Eckel, if you're speaking, you're on mute at the moment. And I'll go ahead and ask another question. Dr. Eckel, if you're able to get off mute, just let me know. Okay, so Christina, let's see. So the question is there a time frame that we should stay within for looking through past lab values? Within 6 months, within a year, or does that time frame not matter?
I would recommend that just based on our other coding instructions for lab values or other things where we can kind of peek into the past for information, if that information was used for that particular inpatient admission, then it would still be relevant. So if you're using a lab value for urinary albumin or urinary creatinine, you are allowed, as mentioned before, to look at previous lab values, but it would need to be those lab values that are used to evaluate and provide care to the patient during that particular admission. So I know that's a little bit of a vague answer, but I think that it's important to make sure that there's some sort of notation that that was the information used for that patient's care during that admission. So going back 6 months may or may not be relevant if, you know, it's suspected or known that those values are no longer applicable to the patient. So hopefully that does help answer your question, although I do know that is vague. So if you have more like as this comes up and you have specific scenarios, you can reach out to your local QI representative for more assistance with that, but that would be my recommendation at this time.
Thank you, Christina. And Dr. Eckel, I see you've come off mute. Are you able to hear us?
Yes, I can. Can you hear me all right too?
Yes, we can hear you.
I heard the question, Renee, or the comment. So I was muted by the organizer. I couldn't get out. So anyway, I'm
sorry
on
about
now.
that.
That's all that's important. So anyway, the idea of a nephrologist and endocrinologist working together, I guess the question comes up, who's taking care of most patients with type 2 diabetes who have little cardiovascular disease risk? And I think that for the large extent, that's the primary care physician, either an internist or a family practitioner. But once I think the eGFR falls below 60, the question is teaming up an endocrinologist with a nephrologist, I think is important. But also, you know, ultimately when a cardiovascular disease event ensues, the cardiologist is involved too. And that's why Mike Blaha at Johns Hopkins, a preventive cardiologist, myself, an endocrinologist, have teamed up to try to promote the development of a new training program called cardiometabolic medicine. That program would involve a nephrologist and a hepatologist because of the relationship of diabetes to non-alcoholic fatty liver disease. So ultimately, I think we need a new training program that encompasses this Venn diagram of overlap between diabetes, chronic kidney disease, heart disease, and now to some extent, chronic liver disease. So anyway, that's my thought. But I think when to get a nephrologist involved with an endocrinologist, assuming she or he is taking care of the patient, is up to some discussion. But I think macroalbuminuria and falls in eGFR, it's just stage 3 and advancing stage 3 kidney disease, yes, the nephrologist should be involved. That's a long answer, but that's my thoughts on the topic.
Thank you, Dr. Eckel. Let's see. There are quite a few questions. So this could be to either of. So for the eGFR value, lab value, if it is documented as greater than 60, what is the best way to document this in the IRP? Should it be documented as 60, 61? Christina, are you able to answer that question?
Well, that's a good question. It's really a static value and not a range that we're collecting in the tool. So, but I do think for purposes of the measure inclusion, if it's, I believe the example you gave was over 60 is the documentation. I think,
yes.
And Dr. Eckel may have some thoughts on this as well, but I think because it's that over 60 range, you would probably want to just put maybe 61 to make sure that it's, you know, included in measures. But yeah, we're not really collecting it as a range currently in the tools. So that would be my recommendation at this point. Although we could look at a range. If that's the way things are commonly documented in the record, we could look at a future update kind of incorporating ranges. But for now, I would probably recommend you put 61 just to make sure that it's in our measures.
Right, I think the ICD-10 codes really relate to ranges, and our definitions of chronic kidney disease relate to ranges, but I think the number itself works fine under these circumstances.
Okay, thank you.
Okay, here's another one. For the timing of the lab results at discharge, if they only have labs drawn on admission, do we collect them for discharge values? So again, the question is for the timing of the lab results at discharge, if they only have labs drawn at admission, do we collect them for discharge values? And then a second question, also you stated we could collect values before admission. What is the time frame for those values?
So I'll answer the second question first. That it's very similar to the previously asked question about how far back can you go. I think you know, if those values were used for that patient's current inpatient admissions treatment plan, then those would still be relevant. And there's not really a time frame that we provided, although I suppose we could look at that, especially if there is something that can provide more clarity there, we'll look at that. And then the first question there was, well, it's already escaped me. Can you remind me, Renee, what the first one was?
Yes. Let me just find it here, and I'm sorry. And I'm sorry, there's been several. Okay, so for the timing, if you only have labs drawn at admission, do you collect them for discharge values? Sorry about that.
So I don't believe what our coding instructions say is just closest to discharge. So I don't know if Dr. Eckel has opinions on this. He certainly is the expert in this and not me, but we could make sure coding instructions capture that a little more clearly, but I'll defer to him to see if he has any thoughts.
Well, the important thing there, Christina, is the fact that renal function, meaning assessed by particularly eGFR calculations, really can be impacted by the hospitalization. So I think this is an incredibly important question to get documented. In other words, let's say someone has an acute coronary event and goes into heart failure transiently for a couple of days after their event, let's say on day 2 or day 3. Ultimately, their creatinine may bump, their eGFR may fall. And ultimately, once the heart failure is managed adequately, we're hopeful that it's going to recover to baseline. So I think this really is an important area to consider further. I would think that closest to discharge is the best way right now going forward, but that could be misinterpreted too in terms of its impacts on events to follow. So this is important to document. Hopefully, most of our patients have a discharge eGFR that's not that different than admission. So if in fact you only have the admission value, you should turn to that. But the most recent one, I think right now, is the gold standard, and that could be modified.
And then I think we have time for a couple more questions. So here's one more. Are there any data on the prevalence of type 2 diabetes and CHF in lower income populations and treatment strategies for those who have limited insurance or payer source?
Well, health disparities in the care of patients with type 2 diabetes and beyond is an important topic of our time. There may be data that relate to that specific question. There are lots of components to that question to kind of sort out. But nevertheless, I suspect that heart failure is much more common in our socioeconomically deprived and diverse populations. We certainly know there's more type 2 diabetes, there's more cardiovascular disease to follow, and there's more renal disease. So I can't envision that all of those factors would not impact the question that's been addressed in terms of heart failure and ultimately outcomes related to heart failure. So those data may be there. I don't have the exact numbers for you today. I'm sorry.
Thank you. So
low cost, by the way, is an important issue, and I think that's something that we're really working on to modify. You know, the GLP-1 receptor agonists and the SGLT2 inhibitors, both are very effective, but they remain costly right now. Hopefully that can change in the very near future.
And thank you, Dr. Eckel. I agree that that's such an important topic and appreciate you answering that one. Christina, I think you may have answered this, but just to clarify, there's a question about what if you don't have the lab values, you don't have those data available in the labs for a patient. How does this affect the facility measures?
So you will, have to indicate not documented or not available on the form. How that will impact the measures is that you will not, let's see, I need to look at this specific measure criteria, but I believe that you will show those patients as non-compliant. So you can use these measures and reports to help you perform some QI efforts at your site. I think, as Dr. Eckel mentioned, that eGFR value can change throughout hospitalization, and while that may not be something that's commonly ordered closer to discharge now, it could be something that your site, your healthcare facility provides some QI to and begins to offer or take those values closer to discharge, and therefore you're able to input those more frequently. So I believe they would just provide you with additional QI efforts. If you're concerned about where or how this might impact any sort of achievement award or other award status, these are currently considered reporting measures and used for your QI efforts at your hospital, but not for achievement or other awards.
Thank you, Christina. And we're at the top of the hour and appreciate all of these wonderful questions coming in. So at this point, I'd like to again thank our presenters for leading today's webinar. Very engaging presentation, so much important information. And thank you all for your participation in today's event and for submitting those questions. Again, after the webinar today, you will receive a follow-up email with the recording and a copy of the slides, along with a survey about the presentation, and we greatly appreciate your feedback. On behalf of the American Association and our presenters, thank you for joining us and have a wonderful day. This concludes today's presentation.
Thank you.